Welcome back to this special episode of The Dental Guys live from the AO Meeting 2024 in Charlotte. I'm John, the Dental Guy.
And I'm Wes, the Dental Guy.
Man, what a great meeting as always. We have seen everything now from, brand new products being developed and being debuted, new textbooks coming out. We've gotten to interview some great authors of new textbooks, new clinical techniques, and also I think we've talked a little bit about the gray areas, right? As we spoke about yesterday, the things we don't know, and the things that are, how much do we have knowledge on? How much is expert opinion? We've explored a lot of great topics, and we're going to continue bringing that to you today.
Over the years, John and I have been a proponent of immediate extraction, immediate placement dental implants. And this field has really blossomed into, like, if you're not at least considering immediates in your practice, you've really missed an opportunity really to benefit in many ways to help our patients get teeth back. I mean, that's what they're there for. And I think the modalities are starting to get more refined as we see more data come out. Somebody that John and I have followed for a very long time, back in some of the original lectures that we were in, has influenced us in a big way. And you might have heard us talk about Dr. Joseph Kahn, and even down to his presentation style. We love going to hear Joe Kahn talk about his connective tissue grafting techniques and how he uses little pieces of sashimi from the palate to be able to enhance patients' soft tissue to get the papilla just in the right place. And I really appreciate Dr. Joseph Kahn being on the show with us to talk about high-level things when it comes to immediate extraction, immediate placement, and how we set our patients up for success. Welcome to the show.
Thank you. Thank you for the invitation.
Yeah, we're excited to talk with you because it's this, as Wes said, there's some of these techniques, and I think connective tissue grafting, which has been around for a long time, has been one of the first stops that we had in this development of the idea of how to preserve facial tissues, facial contours. And obviously you've spoken about that for many, many years. And as we've now seen other approaches come into this discussion, some of which have now more years of data, some of which have fewer years of data. And you've published recently comparing some of those different approaches. So we may want to have a conversation today on, where are we today with connective tissue grafting, socket shield technique, dual zone. These are all different ideas of how to manage some of the same problems. So where does connective tissue grafting fall today? Is this still our go-to approach, or what should we be thinking about?
Well, great question. When you compare tissue graft, root shield, and also dual zone, I think each one of it has its own merits. And I don't think that there's one solution that solves it all. So for me, right now, for personal advancement purpose and also research purpose, I actually do all three, okay? And I have some research on all three. So, talk about tissue graft. What's the reason for doing all this dual zone, socket shield, and all this grafting? The key thing is, on an extraction socket, when we place an implant in there, the challenges is on an open healing socket, the socket is healing. And because of that, the ridge is going to collapse. As you know, once you extract the tooth, the bundle bone is going to be gone. And the buccal plate, depending often to the thickness of the buccal plate. Obviously, if it's thin, some of them will collapse more. So the ultimate goal for immediate implant placement, from the aesthetic standpoint, is to maintain that facial gingival contour. Now, as we know now, when we look at facial gingival contour, we can basically divide into two zones. I call it two zones, okay? So let's start with the first zone. That's from the free gingival margin, go apically to the facial bony wall. Providing if the patient has no periodontal disease, everything perfect, we know that the distance from free gingival margin to the facial bony crest is roughly 3 millimeters. Okay? Now that area has no bone. Therefore, we call it the soft tissue zone. We go a little bit more apical from the bony crest all the way to the tip of the root, or maybe even more. Because that's the bone, we like to call it the bone zone. Okay, so that's a soft tissue zone, So the reason I brought this two zone up is because the ultimate goal for us as a clinician when we do immediacy is to preserve bone zones. Because any one of the zones lacking is not going to work. So now, go back a little bit. You don't know that nobody is going to dispute when we do immediate implant placement, we're going to put bone graft into the socket. That part is whatever. Now, to preserve the bone zone, okay, there's two concepts to preserve it, even in 2024 today, all right? Besides grafting the gap, we sometimes graft outside the gap. In dentistry, we call it contour grafting. Contour grafting, the first term was actually advocated by Daniel Buser. Okay, now when we do contour grafting, there are two sorts of contour grafting: contour bone and contour soft tissue graft, connective tissue graft. So there's two ways to preserve the bone is graft gap, contour soft or hard tissue graft. Soft tissue zones, there are three ways. Well, actually, sorry, there's one more way to maintain the bony socket is to do root shield. Because if you leave the fragment of root, as Herzler and Otto Schur published, you have full nature as if the two have been extracted. So we preserve the bony zone. In terms of the soft tissue zone, there are essentially two methods to treat it. Of course, the first one is to do what you call a scarf connective tissue graft. All right, that means you don't do a contour. Contour, you extend it from the free gingival margin to almost to the middle part of the bone zone. Scarf connective tissue graft, just put it right at the soft tissue zone, like a scarf around the neck. The other one is like what Dennis Tarnell, Steve Chu advocate, is a dual zone. So those are the three methods. Now, what is the best? Is there such a best? All three of them works. But I know now, okay, if you talk about the soft tissue zone, we are in the midst of doing a study. If I don't put anything in there versus I put soft tissue graft versus dual zone, the one that collapsed the most, have the most recession, is you don't put anything in there. So at least in my humble opinion, in 2024, when I do immediacy soft tissue zone, I'll definitely put something in there, either the scarf connective tissue graft or dual zone. Now, which one is better? I don't want to do all the talking, but it's okay, right?
Oh, yes.
So I measure the soft tissue thickness. Which one is best? Okay, no graft, dual zone, and scarf connective tissue graft. We found out that no graft is the one that the mucosal, we don't call it the gingival around implant, we call it the implant mucosal. Mucosal thickness tends to be the thinnest. But then when we go to using soft tissue graft, the scarf tissue graft, it gives us the thickest, of the implant mucosa. Then comes the dual zone. So in terms of thickness-wise, on an average, no graft is around 1.2, 1.1. With connective tissue graft, it's on the range around 2.4, okay? And then with dual zone, it's approximately 1.8. That's the data right now with approximately 12 to 13 sample size each. All right?
Could we enhance dual zone or even connective tissue grafting techniques in the soft tissue zone using custom tissue formers, either customized chair sides, patient specific, to prevent facial bone or facial soft tissue collapse?
Is this all with provisionalization in the study that you're citing?
Great point. They're all with provisionalization.
Okay.
So therefore, now, I mean, when you talk about, I think, tissue formers, you talk about more like either provisionalization or customized abutment and healing abutments like that. Okay. So the current thinking process is when we ever talk about tissue formers or provisionals, we talk about emergence profile.
That's right.
And anything, well, as you know, the emergence profile the area from the implant platform all the way to the gingival margin, that subgingival contour, in general, can be separated into two zones. Okay? There's critical and subcritical, as you know. So let's make sure the audience understand. The subcritical zone is approximately from the implant platform, subgingivally, or implant mucosally, all the way to roughly 1 millimeter right below the free gingival margin. Critical zone is from right about 1 millimeter below the free gingival margin to approximately 1 millimeter coronal to it. All right. So what is the current thinking process is the subcritical zone. The ideal is, emergence-wise, we want it to be straight coming out because that's called the emergence profile. It can be straight. It can be flat, it can be concave or convex, right? So we all know convex may potentially increase the risk of periimplantitis. So now, because of that, we want it to come straight out. And then we know that the critical zone, we utilize it to seal, like a prosthetic seal, sealing the elements underneath, like bone graft, soft tissue graft, so they, so we don't need to put a membrane and things like that. So now, when you talk about tissue form, how should we shape it? Nowadays, actually, we want to under-contour it, almost create a concavity, straight-up concavity, to allow room
Blood supply.
and blood supply for the placement of that tissue graft. And also the own graft, because if you put it too big, you cannot put anything in there. So a combination of that will help to thicken up the tissue. All right. Now, what happens if you don't put anything in there and you under-contour those tissue formers or provisionals at the subclinical zone? That means you will eventually leave a gap between the gingival margin, the facial mucosal, to the prosthetic components. So what happened then? Well, two things. One is it will increase the risk of it collapsing. But on the other hand, because you leave a space between the implant mucosal and the provisionals, blood clots sometimes form, and we also have certain degree of what you call mucosal proliferation or gingival proliferation. Therefore, the key point is this. When we look at the literature, the average facial gingival mucosal thickness is probably around 1 millimeters, okay? And so if you don't put anything in there, what we gain, we still gain something on our data is around 1.2. Okay, so we gain around 0.2. And then when you put tissue graft in there, that's when you gain the most, at least on a 1 year basis. We don't know long term. Okay, 1 year at least particular. That's the thinking process on the tissue formers.
So if you talk about the three techniques, and you've outlined some of the results that we're seeing, and I think then we have to start, maybe the next thing is thinking about potential complications, technique sensitivity, training required. And I want you to speak to that a little bit, because all of those techniques have, again, they could be used in conjunction with one another. Obviously, doesn't have to be alone. But we know some of the complications, for instance, resulted with root shield, with socket shield. There have been some that have been reported, and not always easy to manage. And obviously, technique sensitivity is there. How do you feel about that? You know, is this a technique that's ready for prime time? Because we've discussed that a lot, obviously, in the right hands with the right instruments, and then maybe the same with connective tissue grafting in some hands. It seems to us, and we're just observers, but it seems that dual zone wins in that way because it has ease of being taught. How do you feel about that?
Okay, what I'll do is this. So there are multi-layers on your question.
Yeah.
I'm going to walk you through, if you allow me, step by step, what I look for. So first of all, let's look at the hard tissue zone. Like I say, grafting the gap is no dispute. Now, so one way to preserve it is to do root shield. So let's talk about root shield first, okay? Root shield first published based on the literature, 2010. Herzler, Otto et al., okay? And so because of that, we have generally 14 years of experience. In my practice, my first shield was 2010. So likewise, I have roughly almost 14 years of experience. And so in fact, we had a a publication could be coming out, a randomized controlled clinical trial comparing, how what we do is we look at what you call three-dimensional volumetric analysis. Okay, how much the facial tissue contour collapse compared to no root shield versus root shield. All right, so with this 14 years of experience of root shield, is there complications? Absolutely. So I would tell you roughly percentage of complication, first of all, is I would say at least under my hands. Okay, now you cannot, some people, if you're not less experienced, maybe you have more complications. But under my hands, but of course I start from knowing nothing too, 14 years. I would say complications probably around 5%. Okay, not high, but if I look compared to my first 3 years, the complication is much higher. It's probably around 12%, 13%, because I don't know what's going on. So in general, what is the rule then? First of all, the guidelines to do a root shield is this. I mean, it is very extremely technique sensitive compared to 3 groups you talk about. Okay, it takes a lot more work, and also because why? Because sometimes the goal is that you want to thin out the shell. Right now we know around 1.5 millimeters. Okay, not thicker than that. Probably I like to take it between 1 to 1.5. Too thin, too weak. Too thick, it creates problem that it compromises the space between the shield and the prosthetics and create what you call perforations, okay, or exposures. And that's which is one of the probably the biggest complications. So in general, what we learn about the shield is this, put it in a nutshell. 1 to 1.5 millimeter thick. In general, we want to make it almost like a C shape that bound from the proximal line angle to the proximal line angle. Now, the interesting thing is this, regardless single or multiple implants. Because we did a study comparing, people say, oh, if you do a proximal shield, extend all the way around, maybe you can help to preserve papilla better. We noticed that it's almost as effective if you just take it to the line angle already, okay? So the length of the shield, at least 6 millimeters or more, because if not, you increase the width, what would the mobility or displacement of the shield. Number 3, the shield, to select the shield, you got to have no mobility, all right? No periodontal disease, disease-free, and in general, that's a shield. Now, complications, let me walk you through. Exposure is probably the biggest problem. Okay, why? Because we did not leave enough space between the shield and the prosthetic components. So how much space you need? In my humble opinion, at least 1.5 millimeters. Why? Because if it's too little, you cannot allow soft tissue to develop between it. And so how do you get that space? You either thin out the shield, or you put a baffle at the crest region of the shield, right? Or you under contour professionals or the tissue formers, all right? That's how the number one problem is exposure. Then what other problems do they have? Well, infection, all right? In my career, I have distinctly remember around 3 or 4 infections, and they all turn out pretty bad. Either I need to remove the shield, and then I have soft tissue problem, and it become a big problem. So infection, the key to minimize it is to select teeth that have no infection to begin with. Okay, no root canal problems or no periodontal problems. Okay, so case selection again is very important. Now, couple other things. One other thing is, interestingly enough, we have a case, and you may have read it. We actually publish it. Okay, the first officer's last name is Fang, F-A-N-G. He did a root shield procedure, but the thing is, he did not remove the nerve completely. So now we know, very important to make sure the first step is to go and almost like doing root canal first step, all the way to apex, and you need to do the section all the way. The first part to section the root is follow the root canal. Because what happens in Fang's article that was published at IJPRD several years ago is they found that after root shield procedure, because he failed to remove the nerve, the patient constantly complained of sensitivity. And that it drives the patient crazy.
That's crazy.
So it's very important to that part. But that is the root shield situation. Okay, our success rate is actually very good, and obviously, if you leave the shield, study has shown that it really maintains the facial contour.
So maybe it's ready for prime time, and I think there is some merit to some of the things that you're publishing that allows us to maybe rewrite Frank Spear's article, Ponics versus implants. We're enhancing papilla even between implants.
Right,
which
with that
is,
technique.
With this technique. Talk to a little bit about that, because that's a game changer. We've always have this idea when we take teeth out, we put implants in. Well, that's the most ideal situation when I've got teeth on either side, mesial distal, of an implant. I can generate a certain amount of
Ponics.
That's right.
But now with 2 implants adjacent, you've shown that the socket shield actually enhances that inner implant papilla.
Of course, when I was a graduate student, Frank is one of the most amazing speakers, I believe, and he's a dear friend. And when I was a graduate student, I listened to him about the Ponics too, and I followed those rules. And absolutely, but then you're right, inter-implant situation, the whole game changes. And if there's one thing that's indicated for root shield, okay, in my humble opinion, is to extend the shield a little bit to the proximal to do inter-implant situation, okay? So why? It's worth it. Now, why is it worth it? Because, first of all, let's look at data. We did comparing, when we put a root shield, that means the papillae height, how much you lose the papillae between 2 implants when you put a piece of root shield versus, let's say, no root shield. Now, no root shield, there are in general 3 methods to deal with implant papillae that people use over years to try to preserve it between 2 implants. One is, you extract the teeth and you put 2 implants in, and then you put a provision there hoping to hold that. That's one method. Another method you may have heard of is some people say, if the patient have 2 teeth that's failing, that adjacently, then you first extract only one of the 2.
Yes.
You put an implant in and put a provision and preserve it, and then after the integration of the first implant, usually take around 2 to 3 months, then you remove the second one and go through the same thing. So by doing that, maybe they cut one after the other technique to preserve the papillae better, right? So the third way is, traditionally they extract the teeth and let everything heal and put the implant in, not immediately. So when we look at our data comparing root shield versus the other 3 techniques, significantly difference in papillae loss. So let me give you a data. In general, again, inter-implant situation, root shield, the mean papillae loss after 1 year is around 0.35 millimeters, roughly that, less than half a millimeters. But the other 3 groups all clustered together. All of them lost papillae over 3 millimeters.
That's significant.
And then, what's significant is, remember we talked about one after the other? And really, that article, I mean, I'm actually the first person to publish it. But publication is so humbling because I kind of advocated that, but when we track those group of patients that it seems to hold the papilla better one after the other, over time the papilla shrink back too, because it's just delaying the inevitable. You understand?
Yes.
Because the bone, there's
the
no
biology
support.
wins.
Exactly.
Right.
Exactly. So in a sense, root shield, you're right. The game changer, in my opinion, is really in the implant. But now, facially, as we'll probably later talk about, I mean, using tissue graft, contour bone graft, do so frequently. We get excellent results. It may not be 100%, but it can be 96%. Patients cannot tell. None of my patients can tell. So you're right. Game changer, definitely. In root shield, last but not least, is I think after 14 years, we can consider root shield as probably a pretty decent treatment option if the clinician select the case properly. Okay.
Now let's talk about training for that, because again, in the technique sensitivity of it, and you've mentioned your first 3 years when you didn't know what you were doing with it, or and I'm sure you had training from the best. I would guess you went to their office, or they came to you, and this is what we do, and these are the instruments we use. If someone wants to learn to do root shield technique, where do they go? Because we've always wondered, is this something that you just have to know somebody and you have to watch them? Are there places people can learn this? Are residency programs, for instance, teaching that technique?
Well, I mean, good question. I mean, most residency program is very traditional, all right? I mean, we don't want to push residents to be too adventurous. So because of that, sometimes those techniques are being ignored. And also a lot of times when you have, let's say, older clinicians, I mean, they themselves, despite a faculty, they may never done that procedure. But it's easy to criticize, but we haven't done it before. So where can we get those training? I mean, at this stage, I would say, maybe certain universities, they are a little bit more open-minded, and that's not good or bad. It's just different people have different point of views. Then and maybe if they are blessed to have a couple faculties or one that really have some experience, okay, that's one way to guide them. The other was, I would say, most effective right now is to take courses from the known clinicians. Okay, and there are plenty of them out there. In fact, the funny thing is this: I'm not here to promote, but since we're at the AO, AO is going to actually have me do a program, a 2-day course in July. I think on the last weekend of July, I mean Saturday and Sunday, and that's going to be the hands-on is going to be focusing on model, root shield situation immediacy.
That's perfect. So that's what we need to know is, where people can go for this. And I want to talk about maybe combining the techniques. You said that you may use all three, but there are obviously ways to combine these. And we've seen this in lots of different ways, whether it's combining connective tissue grafting with dual zone, even things like combining, for instance, Barry Levin with the dermal apron technique, using a cellular dermal matrix in combination. Do you see combinations of these techniques showing increased or better results, or is it something that is just it's something we don't need to do all of it?
Okay, excellent point. So remember, we go back to the hard tissue zone, soft tissue zone. Root shield, if you leave a piece of root shield there, basically you, in a sense, you solve the problem of the hard tissue zone at all. It's not going to change. Because of that, if I do root shield, I almost never go and do a contour bone graft or contour tissue graft. You understand?
Yes.
However, the soft tissue zone is the issue. That's where the combination comes from. So I frequently, when I do root shield, okay, I will put something at the soft tissue zone. It's either dual zone technique or the scarf connected tissue graft technique. So that combination is very important. Now, so if you ask me, I want to spend a minute talk about the soft tissue graft. Okay, we talk about root shield, what type of complications. Soft tissue graft, is a little bit less technique sensitive in terms of getting the graft and placing it than root shield. Okay, so root shield is the most technique sensitive. Then comes tissue graft, and tissue graft is a lot less technique sensitive, okay? And then dual zone is probably down here. Got it? So now with the soft tissue graft, basically what are the issues? People sometimes harvest from the tuberosity or the lateral palate. And as you know, harvest from tuberosity, everybody tends to favor that because of the greater degree of fibrotic tissue, laminar dura. So. However, it also has drawback. What's the drawback? Well, I'm sure you all harvest tissue graft, from the tuberosity or the lateral palate. What the biggest issue is, a lot of times when people harvest tissue from the palate, the tuberosity, you will end up usually getting a smaller graft than you want sometimes, right? But then more importantly is, and it's like the flexibility. If you want to graft, put a piece of graft, kind of like you need to bend it around. When it's a lot of fibrotic tissue, it's hard to bend it around. So sometimes because of that, I like to go to a lateral palate, and which is more flexible. I can move it, mold it around the tissues and things like that. Now, tissue graft also has this drawback. Regardless you do contour or scar tissue graft. Why? Because sometimes, okay, especially if you don't seal the area between the gingival and the provisionals enough, if some of the tissue graft got exposed, you will bound to have some degree of necrosis. All right? Now, necrosis will occur even if you do like as a dermal matrix and so forth. Now, but because the beauty of this is, if you have necrosis, our studies show that we have approximately 9% of cases have necrosis. All right? So that means you see, tissue starts sticking out, necroting, and then, you start panicking, okay? Fortunately, most of the cases, despite when your autologous tissue graft, despite its exposed and necrosis, it will heal, and everything most of the time is okay. All right? So now, if I use non-autologous tissue graft, such as a dermal matrix, and I've done that and I get exposures, the reaction is a lot more violent. Inflammation's there. Sometimes I get some tissue retraction. Okay, therefore I prefer autologous tissue graft. And then, so what can we do? The goal is what can we do to minimize that tissue graft from exposing out? Well, sometimes if you feel the contour of the prosthesis cannot seal it well enough, then we'll do some cross-link sutures right at the entrance of the free gingival margin system to bound it down to prevent that from happening. But necrosis is probably, I say, maybe the second most common problem with tissue graft.
This is all really great, but really this hinges on us getting primary stability to provide us with the ability to be able to provide the patient with a provisional custom tissue former. What happens when we're doing an immediate extraction, immediate placement, and we don't get primary stability? Maybe we get some, but maybe the comfort level for moving forward with, a second stage or a provisional isn't there in the clinician, or they don't feel comfortable moving forward. How are we treating those situations?
Perfect. So first of all, let's talk about when you do immediacy, what is stable, what is unstable, all right? So the guideline is not that clear because, a lot of companies, they cannot really tell you, okay, what will be the ideal. People usually use insertion torque as the guideline, right? I mean, sometimes people talk about using those resonance frequency machines, but the thing is, I mean, I'm not rich enough to buy one of those machines, so it's mostly for research purposes, right? So insertion torque, most people will agree that 35 Newton centimeters is kind of like the gold standard. Now, the question is, how low can we go? I would say that in my experience from the literature, some literature report down to 10 Newton centimeters, but they say if that happens, you put a provisional in there, you got to bond the teeth to the adjacent teeth, okay? That's too high risk for me. I would say my number, the threshold is around 20 Newton centimeters. Anything less than that, I probably will not put a provisional in there. I mean, and then what do I do under such circumstances? If I decide to leave the implant in there, now when will I leave the implant in there if the implant is like 20 Newton centimeters? What I do is this. I put an implant mount on the implant and I take my hand. If I can twist it around, I know that it's less than 15. Okay? That means I'm not going to put a provisional in there. And then the next thing I check is whether I keep the implant in there. I try to wobble it left and right or up and down. If the implant not only spin but wobble, implants are coming out. I'm removing the implant. I either put a bigger implant if I can. I would never leave that implant in. Now, if the implant is still spinning but no wobbling, there's a chance for it to still integrate. Okay, so anything less than 20, I probably won't put provisionally in there.
So no lateral movement at all.
No wobbling movement.
Right.
No wobbling. Yes. You try wobbling, if there's wobbling, no good.
Well, I think that this has been great conversation, really going through where are we now with this? Because this has been, I think, in some ways a bit confusing. And the long-term stability. Maybe the last thing I want to ask you about is long-term stability, because, like you say, has to be data-driven, and we see the contour that is unchanged for how long? And what do we currently know about these different techniques? And when does it become significant enough in the literature that you say, okay, I'm comfortable that this is an equivalent technique?
Okay, so immediacy, I think it is evidence-based right now. That means it is absolute a treatment option. We have more than 20 plus years of data, all right? That's more than enough. Root Shield, 14 years at least under my hands. I would say at this point we can start slowly taking it away from the experimental stage. That means if we do it correctly, we should get good results. Contour grafting have been around for a long time, okay? But the problem is a lot of data only show that 1 year follow-up, okay? At least in my practice now, I have like more than 15, 16 years follow-up. And tissue graft, you put the sashimi in there, over time, it will tend to thin out over time. It's normal, okay? The question is, but the beauty of it is it slows down the inevitable. Last but not least, dual zone, we probably have close to around 8-9 years. Now, dual zone, I just want to point out is dual zone can have complications too, although it's less sensitive. Why? Because initially, if you look at Stephen Chu and Tarnell's publication, they talk about using the xenograft. Now, more recently, they changed, right? They was a allograft. And you know why? Because study have shown, even in my case, roughly around 11% of my cases, when I put xenograft in there, I have some almost like inflammation.
That's right.
And then it won't go away.
Yes.
And I don't dare to, and a patient brush, it just won't go away. And I don't dare to go in there and just remove it because I may create a ditch.
Yes.
So now, but then when we do allograft, does that mean it solve our problem? When I do allograft, I still see that several of my cases also have that issue.
They've talked about going toward less cortical bone,
That's right.
smaller
That's
particle
right.
sizes, and all of those things matter. And so I think, like you say, we're still the most modern version of that technique has maybe only been the last maybe 3, 4, 5
That's
years
right.
where we have things to now we start counting forward on stability of that. So, well, I feel like we could talk about this all day. It's wonderful to hear your opinion on this, and to not just opinion, but to see the data and to see the years of experience doing all the techniques, and then being able to compare and contrast real world. That's very powerful.
Yeah, most recently, Dr. Joe Kahn has published on some of these high-level techniques that we feel may be ready for prime time. And we're looking forward to hearing more about, well, what's the long-term evidence say? What's beyond 1 year? I think you've even said it. At 1 year, we all look great.
That's right.
It's what we're looking at 5, 10, and 15 years. And then what's the opportunity and when do we move to revision and how we revise our implant cases? Yes. Patients are outliving our prosthetics. And how do we modify prosthetics? We're learning about those things right here at the Academy of Osseointegration, right down to the nitty-gritty of maybe the techniques we need to be using, or at least exploring and finding people that can help take it to the next level.
Yeah, well, thank you very much for being with us today.
You're welcome.
Appreciate your time very much. And if you've been listening to this and it's got you thinking, okay, maybe this is ready for the next level in my own practice, now we know a little bit more about where we can go to learn more about some of these techniques. I think that's important, and that's what AO is doing for us, not only with meetings like this, but also with hands-on courses, with online information and education, trying to bring the very best to you, the clinician. And so, again, we're excited about how AO is growing and moving forward. So just thank you once again, Dr. Kahn, and for Wes, I'm John. We are the Dental Guys.